Good morning. Good morning, participants. We are starting with our last day today of the in-class session. Okay, so welcome you all to today's last session, which we are having. And this particular session is expert practitioners' perspectives on health policy and systems research. So we have with us today 3 guest speakers. First is Mukta Gadge, who is a public health scientist with extensive experience in health system strengthening, community engagement, and research. She is currently serving as Senior Consultant, Community Processes and Comprehensive Primary Health Care at the State Health Systems Resource Center, Maharashtra. She has expertise in program evaluation, community health initiatives, and health policy formulation. She has a proven track record in designing and conducting capacity building workshops, research methodology training, and health program implementation. She has good track record of publication with contributions in maternal and child health, community health, and epidemiology. She is passionate about evidence-based policy making and improving healthcare accessibility. Several of our Department of Health Sciences projects, along with State Health System Resource Center, she was actually facilitated that and also worked with all of us. Second guest speaker for today is Dr. Swati Krishna. She completed her MD in Community Medicine from Christian Medical College, Vellore. She is deeply interested and has work experience in infectious disease epidemiology and health systems. She was a former national consultant in NTEP at Central TB Division, and she is a current fellow of India Health Policy Systems Research. Currently, she works as assistant professor in community medicine at Bharati Vidyapit Medical College, Pune, and is executing her HPSR project in TB care policies among industrial laborers. Third guest of today is Sri Maulik Choksi. He is a health professional with over 24 years of experience in health systems and policy research, teaching and training. He is a global director of health systems research and policy and leads the health system work at Access Health International. He is mainly providing technical and programmatic leadership for policy engagement, and his work focuses on health system design and policy with national and state governments. He is working with development partners and various academic institutions. So we are very fortunate to have these 3 eminent speakers for today's session. This is going to be a kind of an interactive session, and to facilitate this session, I would like to call upon stage my colleague, Dr. Solomon Salve, who will be moderating this particular session. Over to you, Solomon.
Thank you, Abhay. Once again, I would like to warmly welcome our eminent guest speakers today. Okay, and we are going to have a series of discussions with them, but before we would like to hear their expert advice and like their work in health, HPSR especially. Rather than me disclosing it for now, when you listen to them, you will try to understand why we have chosen these 3 eminent speakers, because they bring in a different level of experience, different kind of lens, because in this last 15 days time, we have been talking about the micro level, the meso level, the macro level. We are talking about different actors within HPSR. And so the reason why you 3 people are here is we want to have a broad spectrum of, how we look at HPSR. So as I've been moderating this session, I'm going to request all of you, all participants, and even those guest participants who are sitting with us, you can start writing down your questions, whatever comes to your mind, or even some questions that we have been discussing with this. And I'm pretty sure our experts are going to help you understand some of the answers to those questions. So you can start writing down your questions, and after the 3 eminent speakers speak, we will have a round of, like extensive engagement discussions with them and try to get answer to some of those unanswered questions. Okay. Welcome you on the stage and hear from your expert advice. Yeah, please.
हाँ that is true.
If you're fine with this, you can use this one also.
ठीक है बघ कुठलं. Okay, thank you very much, Solomon, for your introduction, and thank you, Dr. Kudre sir. So it is really very nice meeting you all, and whatever introduction Solomon and Kudre sir has gave about me, like eminent speaker. So first of all, let me clear that I am not an eminent speaker, but I am one of you, and since last 20, I am going to share my experience, whatever I have gained during my 20-25 years of experience working with as a researcher as well as working with the health system. So today it would be a kind of a discussion session. Whenever you want, you can ask, stop me during my presentation and we can discuss about it. So it is not something like a concrete knowledge I am going to give about it, but sharing an experience, and it is a learning process for all of us, like understanding what exactly the nuances working with the health system and how it affects with the research per se. So we want to understand through that perspective. So today I am going to have that presentation along with me. So what are my experiences working since last 10 or 12 years working with the health system? When I passed out as an anthropologist in 2003, I joined KEM Research Center as a social scientist. And there our project was to establish a health and demographic surveillance system. And so basically to create data, create large data sets in a particular area of nearby Pune. And then during that activity, we also get an opportunity and chance to work on a small projects like understanding the health equities in the community or working on some short data sets. So during that 2-3 years period, I could understand what are the researchers' perspective. I could understand what exactly are the different methodologies, the different research designs, how communities work and how to engage with the community, and all that experience I could get during my 2 to 3 years of experience working with KEM Research Center. Then after that, I also worked on a randomized control trial, hardcore pure research project with Prayas Health Group, which was on a HIV/AIDS, and where we tested an counseling intervention called couple-oriented counseling, which after our research, it proved that intervention is helpful to increase the partner testing or husband HIV testing, which also has a whatever beneficial effect. Now during working in these hardcore research projects, I always felt like there is some disconnect, or there is some missing link, or there is some missing gap, because whatever we produce as a researcher, as a research knowledge, it is not directly getting translated into the community, or for which people from where we collect the data, it is not directly get translated that research findings into that. Of course, in a larger scientific community, we publish paper, it gets reported there, and ultimately somewhere or the other it might get benefited from that research project, but immediately it doesn't get translated into the policy, because we used to discuss, like, if we have got this answer, like this particular intervention is helpful, what are we going to do after that? I mean, we publish the papers and then that is it in somewhere, because it was multi-centric, multi-country study. In maybe some of the countries, they might have reached up to the policy level, like this intervention helps and we can push it till up to the policy level. But I don't know about the India, because their project ends for us. So this was always a question in my mind, how to bridge that gap, and I mean, what are the systems or what are the pathways when we can have the bridging this gap. And I think exactly what we have come here, like health policy and system research is basically talks about it, or that is a path which leads us to bridge that gap between the research and the actual health system problems or health system strengthening. So I think you must have all understanding in last 15 days, like what exactly the components of this health policy and systems research, etc. But now I am going to move. So this is basically to set a premise of my today's discussion, because I have also come from the similar background as you all are here today. So this is a learning process that I started, I mean, looking after these processes, like how research actually works and how we can make difference in people's life through research, because basically every research is basically to understand and help to improve the health outcomes or help people. So with that premise, we start our presentation. So when I talk about health system, I have been working with the health system since last 12 or 10 years. Basically, I am not a hardcore part of a health system per se, so that's why this slide is. I am working at a state health system resource center, which is a kind of a part of health system, but not a hardcore part of. So it is a technical support wing, as you might have already know about it. So it is a technical support wing. So I have written it. It has a typical strategic position. So where it can also influence the policy makers, it can also influence the decision makers, and it can also make a change at the field level or the district level or the ground reality. So basically, so the SHSRCs, all across India, there are, I think, 15 to 16 SHSRC, State Health System Resource Center, established under NHM. And at national level, we have National Health System Resource Center. So all these technical support wings are having very strategic position. So we are a technical support wing. We undertake a lot of evaluation and rapid appraisals activity or for various health programs, like we conducted JSSK, Janani Shishu Suraksha Karyakram, and many other programs. And we come up with some sort of findings, like where are the lacunae and where we can improve this program, and we submit all those reports along with the recommendation to the department or whosoever looking after the respective bureaus. And then we also engage into trainings and capacity building activities for the public health, different public health cadres. So we are having very robust public health system for training as well, but there are some training components like for which department doesn't have their regular workflow. So we engage in such kind of a capacity building activity. We develop SOPs, we develop guidelines as asked by the department. Sorry. Okay. So basically we are having a easy access to both policy makers, program implementers, program planners, as well as the service delivery staff. The system holds trust in SHSRC as an insider. So you might have experienced, like if as a outsider research agency, there is some inhibition from the public health department or a health system, like they are someone outsiders and we cannot give data access to them as easily as they can access that data. So that is an advantage that we have. Like system holds trust on SHSRC because we are a part of them. But at the same time, as a researcher, we also sometimes have to some sort of challenges in having a very unbiased or a neutral attitude. Like if some we have to discuss all the results and the findings with the department, and then we have to publish those results. If there are some issues with some of the results, we might have to revisit all those findings. So there are some challenges as well, but the benefits are much more. So these are the issue from which I have been engaging with the public health system. Now when we talk about public health system, this is a huge system with multi-stakeholder bodies, multi-stakeholder engagements, then the huge HR, huge infrastructure, and then there are multiple levels in it, from grassroots level till up to the state level, and if we are looking from the national level till at the national level. So basically I mean for this easy understanding purpose, I have made 3 important components here. So when we talk about public health system and engaging as a researcher in a public health system, we must understand that all these stakeholders are having a different worldviews or a different background. Like as a researcher, we speak kind of a similar language, or whatever you speak with me regarding the research component or with any other issues, your perspective I can easily understand because I am also a researcher. But this may not be easier for someone elected representative like our minister. So their understanding, their worldview about the problem itself is a difference. So when we engage as a researcher in strengthening the health system, we must understand these different scenarios. Like at the top level, health minister who is a elected representative, then after that we are having a health secretary. Those are the IS officer. So their understanding and their mindset, their working kind of experiences and working strategies are different than the minister. And then after that we also have, so after secretary we also have a health commissioner, so who is also IS officer. And then after that we have a director of health services. So this is basically structure at Maharashtra, but more or less it is similar with every state. So the health director who is a medico. So now the medico could understand our perspective much more closely than some of the others. So but these all are at the macro level, these all are policy planner, policy implementers. So if we want to make any dent or we want to push for a policy, we have to start from this level, and we want to speak with them in a language that they would understand. We cannot use a jargon of words that we usually understand easily as a researcher, but sometimes it is very difficult for a common man to understand whatever exactly we are telling. So we have to simplify that, but their worldview and their wisdom is different, that we as a researcher are not very pro to it, but their vision and their understanding about the problem is very different. So we have to be very clear about them, and we have to convince them like how this policy is going to make a change or how things would happen. So this is at the macro level, policy planner, governance, etc. So areas of intervention that I have already discussed, these kind of issues goes to them. So broadly I have identified like vacancies, policy changes, guidelines, circulars, procurement related, then the finances, how budget is going to go on a which program, etc. All these larger policy decision making related things happens at this macro level. Then after that, even at the district level, we have this administrator who are district health officer and civil surgeon. So in Maharashtra we have both at the district level. So civil surgeon is a specialist and the district health officer is a medico but with PSM background. So both the DHO looks after all the administration part and CS looks after the hospital section. So these are also at the level we can say it comes under macro, because some decisions, some policy changes which are only affecting or at that level can be discussed with district level officials. And then after that we have a block level officials like block health officer. Then after that the meso level, actually the healthcare service delivery component of this part, like we are having the hospitals, we are having the PHCs, we are having the sub-centers. You might be knowing these terminologies, right? Sub-center is at the level of village, somewhere around 5,000 population, one sub-center is there, then PHC, and then after that rural hospital, then the sub-district hospital and the district hospital. It is a continuous hierarchical, and the primary care, secondary care and tertiary care services are provided, and also the referral linkages, referral ambulances, all those services come into this. So here we can think about the quality of services, attitude of healthcare providers with the patients, then the training, capacity building of these technical experts, then the process optimization, because in PHCs or in hospitals how we can optimize the process to have a better outcomes or a good programmatic outcomes. And then vacancies, time, patient satisfaction, all these issues that we have to address at this level. And then at the micro level we can say a community are the beneficiaries of this whole system. So community level, patient, beneficiaries, all those come, and also our grassroots level functionaries like Asha, Anganwadi worker, all these comes at the, we can say at a micro level. So where they could influence, or we can have some sort of areas of influence like healthcare seeking behavior, our IEC activity, demand generation, activating the village level forums and capacity building. So this is a kind of broad structure that healthcare system, when we talk about healthcare system, so this is what broadly a healthcare system. Now this is why I am telling again and again, it is quite huge, and because in Maharashtra approximately we can say there are 12,000 sub-centers, then around 1800 to 1900 PHCs, around 350 hospitals, and then in each district we have a district hospital. So we can, you can understand, to run these hospitals and institutions, there are huge manpower are already being deployed at these all levels. So, and also to run behind the camera or behind the scene, we are having the administrators, we are having the accountants, we are having the technical experts, consultants, everything, Asha. So total we can say that almost around 2.3 lakh HR we can consider that approximately this much HR is already being working to run this whole system. So now we can understand it is not easy to make any change in any program. It is not very easy because there are multiple dimensions and multiple things. So as a researcher, we should be clear about where are we stepping now. So when we go to work with the public health department, we should have understanding about these nuances of the public health system. Okay. So when we have seen the system, but basically these are the 6 key components of this health system. First is governance leadership, that we have already discussed. So now पॉलिसी मेकिंग है, डिसीजन मेकिंग है, कुछ रेगुलेशंस लाने हैं, अगर जीओआई ने कुछ गाइडलाइंस रिलीज की है तो हाउ वी कैन अडैप्ट दोज गाइडलाइंस, वेदर वी वांट टू मेक एनी चेंजेस एज पर द स्टेट स्पेसिफिक गाइडलाइंस में कुछ चेंजेस चाहिए, व्हाट वुड बी द फ्रेमवर्क. सो ऑल दीज काइंड ऑफ थिंग्स कम्स अंडर द गवर्नेंस एंड द लीडरशिप. Then the health workforce, we have already discussed that we are having a huge workforce, so we have to think about their training, capacity building, how are they going to, at their distribution. This is also a huge task, like one person not wish to go in this particular area, and how we can rationally deploy all this huge workforce across the Maharashtra. So this is all comes under the health workforce. Then the service delivery of access to easy accessible healthcare and quality care and efficiency and whatever assured services they should get. So everything comes under the health system. So health system has to think also from this perspective, like how we can have a accessible and assured and quality service delivery till up to the last mile of our population. Then fourth important component that we are all know is and very important is health information system. Unless we have a data gets generated from the field, from the ground reality, we won't be understand what is the programmatic outcome of our efforts or our interventions or whatever program we are implementing. We won't be able to understand. So till how many people we have reached, uska sub calculation whatever we want. So to and fro mechanism say we have to collect this health information, health data. So that is also a huge system that we have to run. Then the financing mechanisms, of course budget hai, allocation hai, how much we have to prioritize, because we are having only 100 rupees, where to allocate that 20 rupees in which program, what are our priorities. So prioritizing and budget allocation is also very important component. Then we are also having the health insurance schemes, then the sustainability, how we can sustain all those schemes. Whosoever we start with any new scheme, we also have to think about how we are going to sustain at least in the next few years or something like that. So financing mechanism is also very important component of health system. And medical products technologies, procurement है, medicine है, new technologies आते रहते हैं, essential medicines, innovations and procurement system. So all these 6 are the important component of this huge public health system, which we should understand before we can think about stepping into any research activities related to strengthening public health. So Now, role as us as a researcher in a health system strengthening. What we can do? We can identify gaps in healthcare service delivery. So we can do that along with them. Then the evaluating the impact. Whatever programs we are being implementing, we can evaluate their impact. कि कितना improvement हुआ है, how much improvement it has caused. Then the informing policy decisions through data driven research. This is very important component that we as a researcher should focus more on that, like informing policy decision, because there is huge data, that's what I have also just now mentioned, that huge data gets compiled, collected in health system itself. If we could have a secondary data analysis, and based on that if we could feedback into the state level decision makers, like this policy change could be made, then that is a very important activity that we as a researcher can undertake. And then strengthening monitoring and evaluation system. This is also very important, because we collect huge data, but we never use it to improve our own whatever programmatic processes or strengthening. So, I mean improving capacities at the block level or a district level to how to look at that data and how to utilize that data to improve our programmatic outcomes. So that is also very important thing that where we can pitch in. So now working with health systems, some of these components you have already discussed in your last 15 days session, like engagement with stakeholders is very much important. Policy makers hai, healthcare providers hai, researchers hai, communities hai, starting from state level till up to the field functionaries. Engaging with concerned stakeholders is very much important if we want to work with the health system. Then collaboration models we can also think about, like public private partnership, कुछ academic institution के साथ partnership, NGO involvement, so that is there. Then policy implementation evaluation, strategies for translating research into action. So this is also area where we can have to think and brainstorm about it, like how we can focus on this particular component or particular area. And challenges and barriers, political है, will नहीं है, या फिर financial issues है, will बहुत है, लेकिन we don't have funds to implement that particular policy. Logistical challenges है, integrating research into policy. So these are some of the challenges that also we have to think about while implementing those policies. Now this is from the public health perspective. So whenever you go in any public health system, or we as a public health system, how we look at the research. First and foremost thing, it is not their priority, or it is not as a public health, from a public health department, I can say, like for public health department, research is not a priority. Their priority is to implement the program, to give services to each and every population of the state. So that is their priority. Now how to fit this component and how to discuss, I mean we have to discuss with them, and we have to make them realize that this is also an important component of improving the public health care system or public health strengthening. So we have to, I mean this is their first thing, this is not our priority, and it is just a researcher comes and they discuss something and they give time, they also get engaged into this, but basically their priorities are different. So this is first that thing comes up. Then why have they come? This is their agenda and not ours. Same, because it is not our agenda, because it is not our priority. So we feel that it is their agenda, they get funding, they come with the public health system, and then उनको करना है तो चलो करते हैं, कुछ तो outcome भी आ ही जाएगा. But तो वो थोड़ा apprehensions are there. Then what new will they tell us? We already know the gaps. Now this is, in many ways this is correct. We as a researcher are new to the health system, we are new to the nuances, or we are new to the problems of health system, but they are working since multiple years, and the generations are working in public health, like so kind of they knew what exactly the problems are there in the system, or where exactly the issues are. So this kind of argument is quite valid many times. So we as a researcher, we have to develop a research question along with them, like whatever things you know, but what exactly are the lacunae, or where are the gaps. So we have to find out that, we have to develop our research problem along with them. So that's where stakeholder engagement is also very important from the initial period. when we develop proposals. So this is there. The terms they use and the language they speak feel alien. So this is also we must understand and we must realize, because I mean if I go and discuss few things or we collaborate with some mathematician and the terminology one mathematician discusses, which are very regular or used for a mathematician, but may not be very easy for us. So similar kind of thing happens when we go with the public health system. Like as a researcher we have to simplify whatever we exactly want to do or we want to undertake as a research, or what are our problem area what we have identified. So that is also there. अगर हम ऐसे बोलते cross sectional study है, longitudinal logistic regression, like the common people or non researchers won't understand this term. So we have to be very simple, clear and concise with our terminologies what we are using. Then our problems are different, they won't understand. So this is also there ki they are coming, our regular issues are different, our challenges are different, and they as a researcher won't understand it. And they are outsider, we are from the system, we know the system in and out. So in nutshell, we are a bit apprehensive about the research findings also and research also, ki what exactly it's new is going to do. And second also, many times they have also experienced similar things, like researcher comes, does a research and then goes, nothing happens with system, no improvement in system. So sometimes they also feel ki why we waste time in this, so if our system is not going to improve at that. So where as a health policy and systems research, we have to bridge this gap and we have to go with that understanding in mind as a researcher, like no, this is not going to add on a larger knowledge, but it will also have some effect on the immediate health system strengthening. So these are few points. So now our challenges and underlying fears, I think we have discussed this. They are finding the flaws in the, वो भी एक fear होता है कि they will come and they will tell that these are the flaws, and then my supervisors will scold me, and I know why these flaws are, but I cannot do. I don't have had that power to improve or do anything, because there are multiple stakeholders into this. So these are some of the challenges. Like, so I feel very apprehensive. And then we are already working in a challenging work environment and compromised work condition, like workload is very high, vacancies are there sometimes, then the logistic issues hai, infrastructure issues hai. It is very difficult. We as a researcher, if we look only a cross section of particular thing, we won't understand the whole system or a whole scenario. There are challenges, and people, in spite of that challenges, system is working and system is trying to improve always. So we as a researcher has to be very kind of non-judgmental in that and not making any remark like how people are doing this or that, because we are looking only through one window and we don't understand the whole situation or whole premise. So researchers don't come up with solutions. This is also important. So problem to pata hi hai, but you are not giving any solution after this research. So why to engage into it? Then governance and administration related transfers. If we engage with some officer at this point and then after gets approval from our research funding agency, that officer get transferred, and then transfer hote, so again we have to start from the scratch. Then unke alag ye rehte hai. Then robust but time consuming approval process, because government has to follow a system and it takes some time for approvals, getting approval from the higher authority, at what level we need to have approval. And then communication gaps, communication delays, because one letter goes from the state level to the district, from district to block, then block to the PHC level. So it takes some time to get that information till up to the last concerned person. Then the information transfer gaps है, guidelines circulars जो निकलते हैं, तो उसमें भी delay थोड़ा ये system से it might take. So these are the challenges and underlying fears. Now what HPSR can provide program managers? So I think if we are running short of time, Solomon, you suggest we can skip, because I think some of this component you might have discussed in your last couple of weeks time. So now whatever you have learned during your last 2 weeks session, HPSR, what HPSR can provide to the public health system or a public health care program managers. So strengthening program design and implementation helps identify gaps. As I have already discussed, we have to identify gaps. Along with them, where are the lacunae, where are the programmatic gaps in policies, and then use systems thinking. So here we need to have, along with us, we have to have a system persons in place to think on that problem and issue and then design an intervention along. So co-development, stakeholder engagement is very, very important for this particular activity. Then provides a framework to assess how policies translate into practice. Then second important where we can give is improving decision making. We can equip managers with evidence. So we are having data, we are having expertise how to look at that data and then provide a concrete recommendations based on that. So it would be a evidence based decision making. So that will also as a program manager it would be beneficial for them. Then enhancing service delivery, identify the bottlenecks where service provision issues are there, identify some process optimization is also very important in any system. So identifying those, assess the frontline health workers experience, improving motivation. HR, as I have already told, in system, public health system, more than in Maharashtra almost around 2 lakhs total HR. It's not only service delivery, management, everything related, approximately that much HR we are having. So at the each level, improving their capacities, improving their understanding about their work also. This will also give a very good outcome for the program implementation. And then ensuring equity and inclusion helps in designing policies that address health disparities and health inequities. Facilitating intersectoral collaboration, I think we have already discussed about this, like engaging with other important sectors like education, finance, transport, rural development. So all those departments also. Then the building a learning health system, encourage reflective practice by using implementation research. So you must have known about the implementation research also. So such kind of things will also build capacities of the organizational capacities of the particular institutions or institutional knowledge sharing mechanisms. Then navigating political and governance challenges, provides insights into policy process and power dynamics. So basically we as a researcher, we have to help program managers on these 4-5 components, then that would be there, that would pave a path for us to work and strengthen the public health system. Now bridging the gap between researchers and the program manager is crucial. So what we can do? Engage with the program managers in defining research question to ensure relevance. This is very important and the foremost important thing before starting your research activity. Identifying the problem along with the stakeholders or a program manager. Then create policy fellowship. This is lacking right now. So maybe we can also think about some sort of policy fellowships for the researchers to work within the government agency. So we can also think about on these lines. Then develop policy briefs and dashboards instead of lengthy academic papers. This is very important component and this has been again and again reiterated by even our secretary sir, like you have to develop some policy brief that would be circulated across the districts like on a particular issue. Like what we can do, what is the problem statement, what issue is there and what could be existing knowledge about it, like what we can do to improve the particular area in a very simple 1-pager or a 2-pager or a very short policy brief which will give very clear cut understanding about the issue and then also for a program managers and program planners and also at the district level to what things we have to do to improve the program. So such kind of policy briefs are important. And then establish knowledge translation platforms that connect policymakers, managers and researchers. So this is also important, and organize evidence to policy dialogues to foster shared understanding. So these are some of the things which will lead us to bridge the gap between the researcher and the program manager and basically to bridge the gap between research and strengthening health system. So this is it. Thank you. So.
Hi. Yeah. So, thank you, Mukta ma'am. Like you really gave us a very broad overview of the way She has brought us into a different world, basically. Okay, for last 10 days, we have been looking from the researcher's point of view. We are trying to understand the system. And one thing what we have realized in most of the workshops also what we do, researchers are least familiar with the organogram of the health system. They many times lack the understanding who are the real actors, and sometimes there are also certain invisible actors whom we ignore in the process of our research. Okay, so the way you have brought in life to that kind of a different perspective from a program manager's point of view. So I think we sitting out here all researchers, and you basically are a researcher. She is an anthropologist, and anthropologists are kind of, like ignored people sometimes because they ask too many questions. They want to go deeper to each and everything. So they are wise and what never end. Okay. But like, I understand the way it must be very difficult for you sitting in a position and trying to work along with the higher macro level actors at the same time being attached with the micro level things that are happening. But the way you have tried to bridge in some of the things, and especially your last slide, which talks about one very crucial things about HPSR is like asking the right questions. Many times we researchers are driven by our own interest areas, but it's not only about our questions, but it's also asking the right questions. And you might be happy to know that during the course of this entire group exercises, like our teams of participants have come up with very valid research questions across different micro, meso, and the level, be it evaluative, exploratory, or explanatory, or descriptive in nature. But at the same time, are these questions also the questions of program managers? Are these questions also the questions of policy makers? Is something like which we need to understand. So I'm pretty sure we are going to come back with loads of questions to you. Okay. So once again, I'm going to urge all of you that note down your questions. Okay, because we are going to have a round of Q&A and like especially for all our speakers today. So once again, Mukta ma'am, thank you so much for making it and giving us that overview. Yes. Now I would like to invite, I would say definitely a colleague of mine because I had the opportunity to work with her, learn from her expertise, who holds a background in medicine basically, community medicine, presently working with Bharatiya Vidyapit, but at the same time bringing in a strong HPSR lens within the work that she has been doing. I feel very attached to her work because we work in tuberculosis program. Okay, and like every time she puts up a post on her WhatsApp, then I say, yes, Swati, that's good. Because she is very much at the micro level. She brings in the micro level perspectives. The other day I saw a picture where she was talking to auto drivers about, like the understanding about what TB means to them. So something which we have been discussing about in the various case studies that you have been doing. So once again, like Swati, thank you for making it, and we would like to hear from you. So we welcome you on the stage, please. Yeah.
Hello. Yeah, am I audible?
Please.
Thank you. Well, good morning everyone, and thank you so much for inviting me here. Thank you, Solomon, for this opportunity. I'm really excited to, interact with the growing HPSR community. I'm just a representative of the growing HPSR community in India, and with the experts sitting here, I can easily call myself a novice in HPSR. I'm also a student like you, so I am also recently introduced into core HPSR, but being a medical doctor specializing in community medicine, I graduated from Christian Medical College, Vellore. So we have been having that exposure to community health research right from our training period itself. I was then, bringing in little bit of background to what I do. I'm a medical doctor, and I have been, after my MD, I was working in CMC Vellore only, but I was working as a national coordinator in a typhoid burden surveillance study. It was a biomedical research project funded by Gates Foundation. We had 16 sites across the country and worked with worked with all who's the who of gut pathology people, microbiology, community medicine people, NGOs, community research people, and it was such an enriching experience working as the national coordinator for that study. I can say I saw the reality of India in many instances. I mean, of course, a glimpse of it, but yes. So that was quite eye-opening to me as a young graduate at that time. And in between as medical college teacher, and then I shifted to TB, tuberculosis. Again, TB has a very personal level connection also with me. So when I was asked, when I was being interviewed for, I worked with the health ministry, Central TB division in Delhi. So while I was being interviewed for the post, I was asked, why would you like to work in TB? So I gave 3 reasons. One was, of course, being a community medicine PSM person, I had this interest in TB because it's much of a social disease. It's not a pure medical disease. It has so many social aspects to it. So that, of course, invoked interest in me, and of course the experience while you were training for your MD and MBBS and everything. So the second reason was slightly academic. So in the typhoid burden study which I was doing, I had a sub-study where I was looking into non-traumatic ileal perforations. Ileum means small intestine. Non-traumatic, the perforations which are happening in small intestine which are not due to trauma. So what are the reasons for that? So we realized that typhoid is still the leading infectious cause, but the second most important cause was TB, which was surprising to me as a fresher, because as far as I knew, TB is something which is such a well structured program. We have effective medicines, diagnostics, we have everything available, so much of awareness about TB, but still TB was the second most important cause. So that reason. And third was that I am a TB survivor myself. I had extrapulmonary TB, intestinal TB, so that of course made me realize that I need to know more about this. So that's how I landed up working in TB, and it was all, you know, like an enriching experience. Like right from regional level, I was transported to the national level, and now I'm looking at India as a whole, and many things were happening, too many things were happening, and which was quite different for me. So we had a lot of activities around during that period. I worked with Solomon also during that time. We were evaluating the best TB care policies in best Brihan Mumbai Transport and Electricity Corporation. So we had a very nice experiences, but there were few eye openers after my stint in ministry at the national level. I had few eye openers. I think Mukta ma'am neatly outlined every point which I have encountered at some point or the other, and the same learnings. So I'm just reiterating those. In practice, this has happened to me. I'm contemporary to you, so you can relate more. Context is extremely important in a diverse country like India. I think as HPSR researchers, that is something which is being drilled into our minds, right? Context, that is extremely important. What works here will not work in another state. Leave state, it will not work in another district. So when you have diverse contexts like in India, it is really difficult to frame a policy one size fits all approach. You cannot follow. You need a lot of space and room for adapting to the context. The next thing was that while working there, I realized mere scientific evidence, as you said, is not enough to translate anything into policy. So as a young researcher, we used to get agitated. Oh, we are generating such high quality evidence. Why can't the government take it? Why can't you, why can't you just implement it? We are giving you all reasons. Why can't you do it? But then sitting there, I realized it's not enough. That is just one part of it. And that's where all your building blocks start falling in. Like it really forms in your mind what is happening. Next thing, we need to address the human element while creating systems or protocols. Now that human element, what you call as software, that is extremely important whenever you are creating any kind of system, protocol, any intervention, anything. Because ultimately, the humans are the ones implementing it, and we need to consider that fact. Humans, all of us are different. We are some 50, 60 people sitting, all of us are different. So the same, like you take a larger system, you can imagine how much of diversity the humans are having. So that human element needs to be considered. So that's when, I was always involved in some kind of research, like you can say kind of operational research. Of course, biomedical research was the core part which I did, but I also did some part of operational research. And like I was constantly looking out for something like a structured learning into what I actually want. I was not able to articulate it, what I really wanted. But I wanted to do something related to policies. I wanted to work with the health systems and, wanted to make a change. Even like maybe at a small level, but that's fine. So I just wanted to do that, and I was constantly looking for it, and with my interactions with my various colleagues, friends, one of my friends, he forwarded to me the call for India Health Policy and Systems Research Fellowship. So I tried, why not? Give it a try. Okay, I applied for it, and they had a very intense selection process. So Malik sir is grinning on that. Okay, so so there was an intense selection process. At least it was new for me, that kind of process. So we had to apply with a concept proposal. Of course, my researcher mind had this very top priority in my mind in the area of TB. I was very much interested into the new TB preventive treatment guidelines, which was introduced in 2021. So that said, one of the major points in that was that TB preventive treatment that till date was being given only to children below 6 years of age who are contacts of TB patients, and to people living with HIV, of course. But this new guideline advocated that you have to give it to everybody in the household, including adults, everybody. So the current guideline is that you have to give the TPT to all the household contacts. So I was very curious into looking into how is it being accepted, like are we really geared up for that? Do we have enough staff, human resources? Are the people really ready with the idea? Are the people accepting about it? Because one thing with TB preventive treatment is that you're going to give medicine to people who are totally asymptomatic. They just have this fact that they have a TB patient at home, but otherwise they're well. What kind of, you have a 6 months treatment. Now there is a shorter regimen too, but the standard 6 months treatment. How will they take it? Do you have any lab tests to show that they are actually infected? No. So it was all the more confusing for me. How do the people accept it? So I wanted to look at it from that whole point of view, from community, from the program managers, how are they managing it? And what was the policy makers thought while bringing it in? Of course, you have scientific evidence, but that is not enough. So that realization was there. So that was the concept proposal with which I applied to this fellowship. Okay. Now, when the interview came, it was another shocker for me. So in the interview time, they asked us, go meet your policy makers. So when you were shortlisted from the concept proposals for the interview, they told us, go meet the policy maker at the level with which you are working in and get in consensus with them. go talk to them and understand whether they also perceive this as a problem, your problem, or do they have some other problem. So as Mukta ma'am said, that what is their priority? I had to go there as usual, like researcher like you were telling, okay, I am going to study this, that and everything. I am not naming the official, but the top TB official told TPT, and that is not a problem, that is an unnecessary intervention. It's wastage of medicine. Actually use the word wastage. It's wastage of medicine. I was surprised because you are here with all the evidence, you are here with all pumped up, going with your concept and like, you know, that question, and I was surprised. Then others were neutral. They were like, oh, we have some issues. So you can see, like, these are slides from my interview presentation. So my initial research question with the concept proposal which I applied was on the top. Okay, it was all about TPT. Then when I went to meet the stakeholders, the priorities listed by stakeholders were these two. Okay, they had problems with case finding in key vulnerable populations, especially industrial area, because the area which I am working is predominantly industrial area. So they had problems in case finding and other TB control activities over there. That was their priority. And second thing was the underutilization of data and the digital systems, which is already well established in the TB program. Hence, I had to change my problem. So I presented these two problems in the POPICO format and everything for the interview, and fortunately I got selected, and I started developing on the first issue. Okay. So that's how my proposal was shaped. So we had a wonderful initiation camp at Delhi, and 20 fellows were selected from across the country, and it is such a diverse group, and it is a joy learning with them, and our faculty are so wonderful. Like, every session was a joy. I'm not you know, painting a rosy picture, but I thoroughly enjoyed those classes, and I really enjoyed working with each of my co-fellows. They all come from a different background, and they were bringing in that perspective. You know, I realized how narrowly I was thinking. Now I am getting insights from each of them, and we formed smaller groups, and we used to discuss our research questions. They used to we used to give inputs. So that kind of a very healthy environment. We have offline connect, like we have groups, and we are still in connect with each other. So that's how that whole HPSR selection process happened. I just want to tell you what we actually learned in that course. So it was structured around 6 months of training and then 1 year of project implementation. Like 6 months of training, then you have to present your proposal, and if you get funded, you can do 1 year of project. It's like that. So we had initiation camp offline, then 6 modules, online modules. Like, we used to have classes every Friday. So we used to wait for that 6 p.m. class, and everybody used to log in, and all of us waiting to see each other. It was such fun sessions, and we had 6 modules: the orientation, health systems, health policy and policy process, HPSR and framing HPSR questions, HPSR methods, and research proposal writing. These were our modules, and especially the second module, health policy and policy process, which Dr. Sudha took. It was so good, and really we realized how policies are made. A lot of, you know, we had fun exercises where we debated about why Maggie shouldn't be banned, and all those interesting exercises happen. And at the end of each session, we used to have exercises, and at the end of each module, we used to have assignments, and they used to score us based on that. So while doing the assignment, for doing the assignments, we had to go meet each of the stakeholders, and one of the exercises was stakeholder mapping, which, you know, like turned around my proposal like anything. And that's when I realized, oh my God, such lot of stakeholders, so many people are involved. And that exercise really helped me get clarity of what I'm actually looking into. So that stakeholder mapping, when we did it like as an exercise, it really opened up my eyes. So like that, each exercise, each assignment made me go deeper and deeper into the problem which I was exploring. So it was carefully tailored like that. So by the end of the modules, I reached into a much refined proposal from what I began. I started looking at things with a broader perspective, that HPSR lens, you say. I mean, I'm still getting at it probably, but you know, I definitely broadened my vision on how I look at problems. And there was jury presentation of the refined protocol, and the grant award happened, and project execution is right now. I am at the data collection stage, and I'm meeting people of diverse backgrounds, and it's so enjoyable talking to them, even though the question wise, yes, policy is lagging, I mean, at implementation level, but I'm gaining new learnings every day. So in between, one of the good things that happened out of this whole HPSR collaboration was that I organized a national meeting on pediatric TB with a health systems perspective. So we brought in a lot of diverse speakers, and we had people speaking from all aspects. We convened this 2-day meeting, and this was really, I would say, a reason why I took this up was because of the fellowship. So I just wanted to share that. So now few learnings. Now I'm almost wrapping up my data collection. So I have few learnings, which many of it what Mukta ma'am already told. So first thing is, health is political. I'm really convinced about the fact that health is very political. Second thing, diverse stakeholders viewpoint, it gave me a real wide perspective from where I was before. Really, my perspective was widened. So that I told you, the entire stakeholder mapping exercise itself started, I mean, it really made me realize how many people are involved in a particular issue. Dilution in policy implementation on ground. So you have a very well written policy, you have a, excellent addressing all the aspects, you have an excellent policy written. But how much of it is happening at the final user end? A lot of dilution happens, and that happens, that has to happen, okay, because you are not in a closed system, you are in a social system, you are in an open system. So of course dilutions will happen, but how much of dilution has to happen? Yes, that we have to think about. And again, I am now less judgmental about how people respond to changes. That is one huge change which has happened to me at a personal and professional level. When people are not taking up changes, good changes, responding positively to changes, not adopting good changes, I am less judgmental now, because everybody's thought process is different, and now I have become very less judgmental about it. Now I started considering the whole health system while approaching problems, not the medical aspect alone. I mean, being a community medicine person, of course, we had that community approach towards problems, but now that is even more widened. Also, acknowledging power. Onboarding people in power as advocates for change can go a long way. Now, in whatever intervention, community intervention, or any small, even for a personal work level, acknowledging power dynamics and navigating through it accordingly really makes a difference. You can't remain stubborn about it, because that is something which exists. And for example, you're doing something in a village, you're doing a survey in a village. It's always better that you onboard your Gram Panchayat Sarpanch, for instance, in the medical college I'm working, we are doing family adoption program, where medical students go into a village and do the survey. So the practice there is you get a permission letter from Panchayat Sarpanch 2 years ago, and 3 years program is running. After that there is no contact. As ma'am said, there is no going back. So now I have started telling my team that no, we have to involve the Sarpanch, Gram Sevak, everybody every time we go to the village. Tell them we are doing this, we are doing a health camp here, okay, let them come, let them get the data, provide them with the data, they would need it, they will be interested in it. And when we did an ACF, active case finding with symptom screening, I made the medical students do that. So the data, presumptive TB individuals who were identified from that activity, my team did not feel it is important to communicate to the local ASHA, but I told them we have to, and I called up the local ASHA and told madam that okay, madam, see, we have identified 4 presumptive TB based on symptom screening, you may take further action because they seem to be symptomatic. She was so happy, and she started cooperating better for the further camps and surveys. So that is how the whole system should work. So bring in changes at whatever level you are working in. Agility and adaptability are key to getting outcomes in health programs. That is another learning which I had. Now way forward, we have an amazing network of HPSR colleagues, so looking forward to more collaborations. That is one thing in mind, and another, this would rather be a learning, I'm not sure, but I always think that going hand in hand with existing systems, say government or whatever the systems is, that is always better than introducing something de novo. I'm not telling 100%, sometimes you have to introduce things de novo, but always try this part first. Try to work with existing systems, try what change you can bring about. So I think, and going completely as a parallel system, it will always dissociate you from each other. So I feel this is something which I want to adhere to. And of course, sowing seeds of HPSR thoughts in my students, UG/PG level. I try to introduce that building blocks at all levels so that they think that way. So this is something, my journey. Thank you so much.
Thank you, Dr. Swati, for making it such an interesting session for us, such an interesting lecture. I am jealous. For the reason, like, I would request Maulik sir, like, if given an opportunity, I want to unlearn and be a part of the HPSR fellowship and relearn the things, okay? Such a wonderful experience, the way you have like brought in the perspective and portrayed, like your own journey, starting from purely a biomedical background person and then entering into an HPSR. Okay. And picking on things, like which we all social scientists, look that we could contribute into biomedicine. So you have brought in that perspective, not only a perspective, but it's a complete paradigm shift, I would say, that you have brought in. Secondly, like most of the times when we were discussing, people are always challenged by this idea that can we, sir, work on one particular disease? Or can we just do one program? And I think like this is a great example where we always say that you can use a program or a disease as a tracer and see across the system building blocks, how it cuts across different building blocks, how one building block can have an effect on another building block. So the case study challenges that they are dealing with. Now I think, look, your presentation has also given him, they have enlightened, I would say. They are enlightened with this idea that yes, the case studies that they are working, they can definitely relook at it from the HPSR lens, from the building blocks lens. And we have been talking about, like anybody who wants to come in HPSR, he cannot do away without the building blocks framework. It is one of those frameworks which, like gives us that whole understanding that how we can look at system from different perspective. And thank you again. One interesting thing which I noted from one of your slides, like you have become less judgmental. Okay. Okay. So I think like you're falling onto the anthropological side. So as anthropologists, we are trained to be neutral, and I'm happy, like we are pulling people from medicine background into that perspective as well. So once again, thank you so much, and I'm pretty sure we'll have some more questions, and even during the break time, we will have more one-to-one round of interactions with you. Yeah, thank you so much. Yes. Well, with this, I would like to invite senior speaker, okay, like Shri Maulik Choksi ji, okay. We have known Maulik sir for last almost 25 years for now, and the way he was 25 years before, okay, the same humble person, okay, the way he entered the department yesterday with that humility and, like that openness, that enthusiasm. Okay, we had a lovely dinner last night. We had so many discussions over dinner, and he said, like, I want to make this session more dynamic. Okay, don't want to show any slides, but I want to talk to the participants, and through them, I want to talk about the macro level. Okay, so we heard from the program person side, we heard from the researchers side, but we as participants also need to, like, start thinking about the macro side. And I think, like, there's nobody else other than you who can give justice to this topic. So thank you, Maulik sir, for making this, and all up to you.
Thank you very much indeed. You can hear me, right? You are going to speak in my session. I'll give you a 2007 incidents, okay? And you are going to help me answering the reasons behind 2007 incidents. One state government, it has one of the best health system indicators in our country. And when I say health system, let me decode. My two previous speakers are fantastic, right? No doubt about it. But for me, they only touched about 30% of health system. And the reason I am saying is that if I look India as a country, 70% of health system is private. And we haven't spoken about it, right? We have only talked about hierarchy in public health system. We have spoken about community engagement, right? But we haven't spoken about what happens when a consumer or a beneficiary go to private health system, right? So the question I'm asking brings about right from a role that a state department plays to what happens in the world. Let's try to decode it. So again, coming back to the question, 2007, one of the best performing state in our country with the best procurement system in our country was not able to supply antibiotics to its population. Right? Is the question clear? So obviously, if medicine is not available, and I am taking antibiotic as an example, there were a battery of medicines which are not available. So why the best procurement agency? The agency is also kind of certified by World Bank to procure for national programs. So systems are too good. But still, it could not supply medicines to its population, and obviously it's going to affect health outcome. So a person who looks down gets caught. Okay? So ma'am, you, why? Why do you think that state could not provide medication to its population? What could be the potential reason? I don't want a clear-cut answer. What could be the potential reason behind it?
Funding.
They had enough funding, as I said, one of the best procurement system, and one of the element of best procurement system is processes and funding. So, guess negated. Ma'am?
Maybe, as you said, the involvement of private sector might have influenced how they procure things. Maybe other agencies in the environment might have
be specific.
influenced.
You know, that's health system policy research, right? You need to be specific. You can't be too broad.
Influence of private agencies on the
Be specific. So, hey, explain me, when you say influence of private agency, what does it mean?
other procurement agencies, other
State-
than the one that we're talking
State
about.
has one procurement agency. The state procures for entire state.
Um,
So there is no other procurement agency for the state.
okay.
But it's a good point. I'll come to that point raised. But in that instance, it was the most progressive state, and it was the only state which had the strongest procurement agency. Other states were learning from that procurement agency. So they were in a very nascent stage. So that competition between states, right, did not exist. Okay? Well taken, point well taken, but that was not existent. Right. Sir? Yeah. What could have happened in that state? They were not able to supply medicines. And a 22 rupee medicine had to be procured at 70 rupees. I'm coming to you, ma'am. No answer? Let's go to ma'am.
Could it be that because this was as you mentioned, that the state had a very strong health system, so they were focusing on other priorities, and this being a basic need might have been
No, it was
overlooked.
not the case. They wanted medication. So the procurement agency function is well defined, right? Each and every state buy medicine based on the state's essential list of medicine, ELMs. Quite defined. It has got 260 medications. They roll out, float out tenders, and the tenders are applied by, who applies to the tendering system? Pharmaceutical companies. Now what do you see? Now where have we have broken the boundary of state health system to pharmaceutical company. Now pharmaceutical company is it's a market, right? So any behavior in the market where we are agnostic, the public health system, we talk about the public health system only, but that market behavior affected the, so there were no tender application. Let's come to first point. The number of tender application to that particular year went down substantially. Now again the question comes, every year we were applying for supplying medication to that particular state. Why this particular year we are not applying? Change of? No. That's another level going up now. So we have gone from public health system to market. Now we need to see what affects the market. What will affect the market? Raw material availability. Fantastic. Sir, what will affect the raw material availability?
Maybe that company which is supplying for the state, they may be looking for they want to hike the price of the medicine. They may want to increase the price of the medicine.
Absolutely, that could be one of the case. But that prices cannot go from 22 rupees to 70 rupees, right? There is no justification for that, right? We are going in the right direction. But again, I'm saying, see what will affect the market behavior. You are again going at a enterprise behavioral level. At a market level, what could happen? Raw material, she said, right? So, yeah, please go on.
I guess sudden increase of demand can affect the market behavior a lot.
That increase of demand, again, it goes to the state point. If the state procurement agencies are stronger, it happened much later. In 2009, they again faced the same problem for certain group of medicine. It was increase in demand. So I'll come to that point because we need to deep dive into that. Market behavior. What will affect market behavior?
Maybe the import-export.
Import-export. Who said? Very good.
Global.
So, senior colleagues, right? You guys won't be knowing it, so I'm asking. What happened in global arena in 2007, which could have affected market? API market, active pharmaceutical ingredient production market, elderly people like us. They would have not known. 2007, they might be just maybe in school or 7th or 8th standard. TRIPS was 2004. I won't waste time, I'll come to the point. 2007 was Beijing Olympics, right? During Beijing Olympics, China, to to decrease pollution level in Beijing, shut down all the production plants, right? All the incubators which were doing fermentation were shut down. The shutdown of fermentation decreased the availability of API. India is a good kind of packaging industry, not an API manufacturer, right? That API going down decreases the production cost of, because you had to buy API from somewhere else, and that resulted in kind of 100% increase of the price of an antibiotic. So if you are given 100 rupees to buy medication, and if particular commodity price goes on a higher level, obviously you are going to cut down on availability of medication from other people, right? Other segments, other therapeutic segment. Overall, it affects your health outcomes. This is health system policy research, right? When we talk about behavior of an individual or behavior of a procurement system or a public sector, that behavior is not isolated behavior, right? That behavior starts from what's happening in global arena. So now today, and we were talking about in the morning, what's happening in global arena? You should be knowing this, right? Sir, what's happening in global arena which is affecting health system in a very, very bad manner? Aid which is provided is getting discontinued. Now look at the systems. If I go to sub-Saharan Africa, 90% of my health expenditure is through donor aid. What will happen to me now? So today, as ma'am was saying in the morning, there are medicines available in depot, right? But they are not available to consumers because all the resources, human resources in between has been taken off. So when you say that I want to study, let's say access to medicine, right? Access to medicine is not only a component which is driven by consumer behavior. I'll again give an example. When we start talking about vaccines, we know there is a religious connotations of inoculation. There are a group of communities who don't get vaccinated because of XYZ reason. Whether it's right, wrong, we don't know. Ghulam Nabi Azad, I can name him because he was asked this question, and if you can cut it down, cut it off. So he was our health minister, right? He went to UN General Assembly. In UNJ, he was asked, sir, you have got 100% of vaccine wastage. How do you justify it? Now, can someone help me in answering how 100% vaccine wastage can happen? Very simple calculation it is. Very simple. Sir, you study at, you are at part of AIMS, right? How can you justify 100% vaccine wastage? What could be the factors behind it?
Probably there is a vaccine hesitancy among the community.
That contributes to 5%.
People were not aware this vaccine is going to introduce into the community.
Vaccine is a supply side program. So, researchers, when you answer a question, there is a counterfactual to it. And when you present this to policymaker, it will exactly work this way. What ma'am was pointing about, right? Policymakers, right? He will give you 5 minutes to present your 1 year of work. So we call it elevator speech. In that 5 minutes, you need to present on 1 year. Justify 100% vaccine wastage. And I'm saying justify. It was happening and it is correct. Justify it.
Maybe they don't have a cold chain system properly, which led to a
25% wastage. So we accumulated 30%. I'm adding in numbers for you. Anyone at back, you can answer, right?
Maybe all the vaccines were there in the state level only. They are
Sorry?
not. Maybe all the vaccines are expired in the state ILR itself.
So when you go for a vaccine inoculation, you don't divide. UIP, you just follow the schedule. A, B, C, D is given, A, B, C, D is given.
Okay.
So we are still at 30%.
Maybe the time when they have procured it and when it got supplied, all the vaccine got expired.
No, wastage incorporates everything.
No, first was cold chain wala problem.
No, but wastage, when I say wastage, it takes everything into account.
Okay.
So our coverage rates are around 52 to 60%, our coverage rates. 40% comes from there. 30% you have already given me. So mota 70% of vaccine wastage is right on the cards. And then 15-20% come from here and there. So now look at me as a health financing guy. People keep on asking more and more public money for public health system, right? So how does the budget happens? Ministry will give its request to Ministry of Finance, and then Ministry of Finance will allocate based on the tax pool. That everything is tax kitty, from tax pool it gets percolated. Will Ministry of Finance agree to it? Will Ministry of Finance ever agree to enhance expenditure to healthcare when we know that we have got huge percentage of wastages? Now, who is responsible for these wastages? Who is responsible for that wastages? Is system, right? And system is made up of individuals. So if ma'am is saying that we have got 2.4 lakh healthcare professional in Maharashtra, and if let's say Maharashtra is wasting around 25% of vaccine, those 2.4 lakh people are responsible for it. And then it goes to another angle. What motivates public healthcare professional to work in a difficult situation? So we did study for nursing cadre and hospital doctors, right? And again, I'm going to the market functions, how market works. So, is anyone, a lot of you are MBBS doctors, right? MBBS doctor here or BDS doctor, right? How much fees did you pay in a year? 3 lakhs, right? So, your MBBS degree for 5.5 years could have gone 15 lakh rupees, right? Anyone has done MBBS from private college, private medical college, right? It's, I would say it costs you around 1.5 crore rupees to finish your MBBS. 15 lakhs, 1.5 crores. Now, if she goes to public health system, what would be her motive? For her versus that 1.5 crore. Who would be more responsible to health system? Both would want to earn money. पैसा चाहिए यार, बिना पैसे कैसे चलता है? पैसा चाहिए, मेरे को भी चाहिए. इतना कमाता हूँ फिर भी कम पड़ता है. So वो problem नहीं है. लेकिन who would be more responsive to public health system? Or at least who would come to public health system to work? Right? Because the aspirational level and the grooming of those people is very different. Versus that guy or girl has invested 1.5 crore rupees, the primary motive is to recoup that 1.5 crore rupees, right? So when a practitioner needs to recoup, what is going to do? If I want to recoup my money, what will I do? Increase the expenditure, right? Even if MRI, CT scan is required or not required, I'll prescribe because I'm going to get some differentials out of it. Medication would be driven by some behavior, right? So what is driving that public health professional behavior? Is the education policy that's driving the behavior. And that's what health system is. When we talk about health system, we get too narrowed in terms of A, B, C, D, E, F, G. Health system is not that. Health system is much huge, much bigger than that, right? India is not going to suffer with what Trump did as far as closure of aid to lot many countries, right? We will be suffering in certain programs because programs were funded substantially by aid money, but system as a whole was not funded by aid money. So only if let's say we are spending 100 rupees, right, only 38 paisa was coming from aid in our country. Only 38 paisa, it doesn't matter. 38 paisa aid, 65 rupees were coming from state, 35 rupees were coming from center. So health is a state subject. So when we critique a policy of national government, right, state governments also need to take responsibility of how we are behaving, because public health is your function. And we start looking at again health system perspective. If we want to decrease health expenditure, where should I be focusing? If I want to decrease my healthcare expenditure, where should be my focus? बहुत simple answer है. People not coming to healthcare centers. If people come to healthcare centers, doctor needs to prescribe, medicine will go, test will happen. People should not come to my healthcare centers. And how will it happen? Right? So theory of focusing on prevention and promotion is this, right? That when you decrease or when you make people health stronger or better at a community level, right? You don't need to come above the level. And that decreases the dependency on secondary and tertiary care because they are expensive. This is what health system is. So, and see what I have talked in kind of building blocks of health system. I spoke about medication. I spoke about human resources. I spoke about financing, right? What is missing? Missing is data now. Ma'am said we have got huge amount of data. If today I want to do a expenditure study, I am relying on NFHS or NSSO data set. Or I do my own survey, primary care survey. Now primary surveys are very expensive, right? They cannot be done year over year. So I rely on 4 year down the data. Now in 4 years, look at you, look at people around you. How much have we changed in 4 years? Can I rely on this 4-year-old data? No, right? And what is the policy initiative that we have to address this data issue? What is the policy initiative that we have? Currently, we are doing something on day-to-day basis which is accumulating real-time data. ABDM, right? We are collecting data repository. But when data comes, transparency comes. When transparency comes, there is a pushback. People don't like transparency, right? So if you look at the reasons of ABDM being adopted at a lower pace is because of transparency. But what we need is a stochastic data system so that whatever data is collected is real-time data because that matters the most. And if I say that a village, the morbidity level was morbidity level of MMR was 42 in 2018, bloody hell, it doesn't make any sense. In 2014, the morbidity level have gone skyrocketed or plummeted. And I need to design policy based on current status, not what was happening six years back, right? And this is what policymakers continuously struggle. And they are part of the process because we don't have robust data system, both in terms of what are the input and what is the expenditure. Now tell me, if we talk about public health system, what is the biggest hue and cry that we make in terms of human resources? Shortage of resources, right? Shortage of doctors. We keep on saying that we have shortage of doctors. Do we really have shortage of doctors? It's distribution effect, right? And again, if you go to, we emulate, we learn a lot from high income countries, right? In high income countries, primary care is not driven by doctors, right? Primary care is driven by paramedics, nurses and trained professionals. Can we do that? Can a nurses in our country given a prescription right? At a policymaker's level, it makes complete sense, right? But in an organizational system, medical association, state medical association, they will never allow because it takes the monopoly of doctors on health of people. And this is what we have. So I come from London School of Economics, so I have an economist mind. I am a trained economist. So I look at what money does, right? At times it's bad, but I'll again ask you a question. I forgot something. Okay. At a policymaker's perspective, we designed a curriculum, right? So in Chhattisgarh, there was a model tested on rural health medical services, RMHS, BRHMS, Bachelor of Rural Health Medicine Services. That is a course offered now. So what it does that it trains people for 3.5 years. that 3.5 years people cannot go for PG, they cannot go out of country, and with an assumption that 3.5 year trained people can replace medical doctors, they will stay into their community and they will enhance access to healthcare. But the curriculum approval and agreement from IMA took 6 years for it to happen. And now also it is approved, but it's not rolled out. So when we start talking about health systems and policy research, you need to look at those nuances. Micro, meso, macro. If you look at them in isolation, it doesn't work, right? If in a medical, if in a delivery center, you have got medicines, but you don't have pharmacist, right? Or you don't have a doctor, that medicines are going to be lying on the shelf, right? And when you do a research on access to medication, we forget the role of pharmacist in that. In one of the northern states, we did a prescription audit, right? So we went to 30 public healthcare facilities and we wanted to see what kind of prescription practices were happening. We went to 30 primary healthcare centers. Each and every primary healthcare center had same prescription. Same prescription. Why? So in the morning, the pharmacist will come and give doctor, these are 8 medications that we have in our center. He will write 3 out of 8 to everyone. That's the reality. And there was no pharmacist, there was a 10 standard guy who was managing the drugstore. That's the reality. So no matter how strong you make a procurement system, right? If your health system does not have pharmacists, if you don't have good kind of drug delivery centers, it doesn't make sense. So your infrastructure becomes equally important as financing, as pharmacist, as procurement agency. Anyone missing in the wheel, your wheel won't work. So when you look at HPSR, look at that perspective. Really, it meets all the objectives or not. Getting consumer view is very, very good. But as said, if that consumer views are not backed up with policymakers' view, it is of no point. She had to change a research question, right? Because she learned that this is what the real ecosystem is. So please spend some time in understanding the ecosystem in which you are going to do your research study. So now I look at my diaries, I had some points out there, I just want to see if I'm missing anything. Public private mentioned, agenda mentioned, date mentioned, stochastic mentioned. Yeah. This all we are saying when systems are working, right? Everything is perfect. What do we do in COVID? If there is a shock like this, you have no data, you have no people, right? How do you create policies at that time? I was talking with ma'am in the morning. तुमको market खोलना चाहिए कि market बंद करना चाहिए? You should be opening market, you are shutting down market. How do you decide? Both has got pros and cons, right? So certain policy decisions are never going to be evidence-based. Because, and especially when things are emerging and they are new. And one thing that can come handy at that time is modeling, right? You have talked about economic evaluation of road traffic. What is that? You are doing some research on economic evaluation, right? Road traffic accidents, right? And you are looking at health systems lens, right? If you look at ICMR GBD report, the topmost line item of causes of death is road traffic accident. Now, which ministry is responsible for maintaining road? Is it health? It's PWD, right? Do you have data of PWD? How are you going to do economic evaluation if you don't have data? And it again breaks the boundaries of health system. That now, if I look at Delhi, I come from Delhi. So very recently, Insurance premium in Delhi has gone up by 15%. Yeah, and you know what the cause is? Quite common, quite obvious. The insurance premium that you pay for 50-year male in Pune plus 15 years male in Delhi, there is an incremental 15% cost to Delhi male. Why? Everything is the same. Morbidity pattern, age pattern, income pattern, everything is the same, but still I pay 15% more. Why? Pollution, right? I am not responsible for pollution, man. But I am paying 15% more. So this other systemic effect which has got effect on your health outcomes and the money that you pay. And see, if there will be lot many people for whom this 15% would be on a very difficult side, they will stop taking insurance. So what happens? That they will delay their access to health care because they don't have insurance. And the delayed access to health care will result into shock. And shock treatment is always expensive than a preventive treatment. We just spoke about it. So this pollution will now drive market in a very different fashion. So as a bottom line, when you start looking at that system, look at individual. The individual is a part of an ecosystem, and that ecosystem is affected both at a micro, meso. So I would use this word at a state level, federal level, and global level. People in sub-Saharan Africa did not get COVID vaccine, right? And henceforth, the government are now focusing towards local production, localization. And high-income countries were not able to supply because they did not want to supply. Political economy. Again, the point that ma'am made. So health policy system research is much more complex than you can even dream of. But I worked from 2016 till 2021. So everyone knows ABDM, right? The ABDM first conversation happened in 2016. 2017, there was a consultant hired to draft what ABDM in India should look like. 2018 March, the first paper was produced on ABDM, on the architecture. 2008, because he was an international consultant, 2018 till 2019, there was a socialization, we call it. All Indian experts got involved in kind of making sure that it is aligned to the needs of India. In 2019, one government department accepted it. In 2019 November, it was politically accepted by they released a book along with the donor. In 2020, it went to socialization with other ministries, right? Because it was created by health, but it had a role of Minister of Information Technology, Finance, everyone had a role out there, commerce, industry. And after in 2021, on Lal Killa, Pradhan Mantri announced this policy. 4 years. An expenditure of around $10 million. This is how policies are getting framed at a macro level. They're expensive, right? So any default in this process, losing that $10 million. So be very mindful when you do a policy advocacy, how strong it is, how inclusive it is, and how profound it is to make its impact on health system. Thank you. I don't make slides because these things cannot come on slide. You can take this now.
Thank you, Maulik sir, again for that enlightenment that you have sparked in us. I think I should go back to LSE. Okay, like LSE is like neighbor to LSSTM, so I think like I spent some time at LSSTM, so I wish I would have also spent some time at LSE. Okay. Yeah, but like something, like as a part of this curriculum, which we were not able to touch upon, was the economic side of the health policy and systems research. And I think you have very well filled in that gap, and like help us rethink about, like our case studies, rethink about, like the way we have been looking forward to it, and brought in a very crucial element of the policy into this discussion. So this also stimulates and, it takes us back to our lecture on last Saturday, where we talked about different modes of policy making, different patterns, and after all, like policy is related to politics. Okay, so the macro politics, the low politics that we discussed upon, and the way Maulik sir has linked up all of his years of experience into the systems block. Okay. He didn't put a slide, but the way he was talking about, he brought in experiences and connected it with different. And I'm pretty sure you have gone to the next level. You have started thinking about, like how I can think at that macro level now. Okay. Even if our studies are happening at the micro level, but there are a lot other forces, like contextual forces that are contributing to it. So one thing that we miss upon as a researcher is like to link up our whole understanding about the micro and meso with the macro. So once again, thank you so much, Maulik sir, for making it. And I'm pretty sure because this all thing is getting recorded, these all recordings are going to be available to our students, and it's live recording. So please revisit these YouTube links and try to unpack. I would say like I will just transcribe this entire 3 lectures, codify them, and then start re-looking at my HPSR thing. So once again, thank you so much, and I would like to ask you to give a big hand to all our 3 eminent speakers, okay? We are going to move into our next session, which is about winding up the valedictory program, okay? So what we are going to do is, I know you all have your questions ready with us. What we could do is like during the lunch session, we will have a round of interaction with all our 3 experts. We will talk to them personally as a group and see to it that, like we get answer to our question. So thank you, Maulik sir. Thank you, Mukta ma'am, and thank you, Dr. Swati, for your enriched enlightenment to the students. Yes, thank you so much. Yeah.
Good afternoon, everyone. To our esteemed guests, faculty members and participants. I am Shivani Khandolkar, student of Masters of Public Health. It is my privilege to welcome you all to our valedictory session of Gyan program on health policy and system research methodology, organized by Department of Health Sciences, Savitribai Phule, Pune University. It is indeed a movement of pride and honor to have such esteemed dignitaries with us today. As we embark on this special occasion, let us take a moment to welcome our distinct guest to the stage. It is our utmost honor to welcome our esteemed chief guest, Professor Parag Karkar sir. Sir, we kindly invite you to join us on the stage. We are honored to welcome Shri Maulik Choksi sir, who brings years of invaluable experience in health policy and system research. Sir, we kindly invite you on the stage. Yes. Nextly, with great honor, I would like to invite Mukta ma'am on the stage. Also, Dr. Swati, please join us on the stage. With great respect, we also invite Dr. Solomon Sarvi sir, National Faculty of Gyan Course. To begin with this auspicious event, I would like to invite Dr. Abhay Kudre sir to extend a warm welcome to our esteemed guests and participants.
Yes. Respected Honorable Pro VC sir, all renowned delegates, participants, and students. We are here today for the valedictory session of this GAN's 2-credit course on the health policy and systems research methodology and introduction. We have in this course 20 participants, and they are coming from renowned institutions in India. To name a few, All India Institute of Medical Sciences, New Delhi, National Institute of Epidemiology, Chennai, Manipal Academy of Higher Education, and University of Delhi, and our own Pune University students. Again, to reiterate, if we try to see what made us think about planning this course, it was our constant quest at the faculty level to adapt our department's teaching programs, both MSc and Master of Public Health. We are adapting ourselves to fast-changing landscape of National Education Policy 2020, and that is our main driving force. We already have a solid interdisciplinary approach inbuilt at our department with a history of last 31 years. We strive to further build this interdisciplinary spirit and our adaptability in changing situation, changing contexts. At the time of this session, we take this opportunity to thank our Pro VC sir for his constant support and valuable guidance to us at departmental level, which keep us going and allow us to undertake newer and newer initiatives at departmental levels. Thank you, sir, and the entire university administration. Over to you, Shiv.
Thank you, sir, for this welcome and insightful introduction. Now, it is our honor to felicitate our esteemed guest. I invite Professor Parag Karkar sir to present a token of appreciation to Shri Maulik Choksi sir. Please give. No. Thank you, Gayatri. Now it is my honor to invite our esteemed guest, Shri Maulik Choksi sir, from Access Health International to deliver a keynote address on the topic of expert practitioners' perspective.
Thank you very much for having me here. I'll start from first, it's a fantastic program, and building in young colleagues to get into health policy systems research is very, very important. And the reason I'm saying is I just share an example, a personal example that and a challenge that I'm facing right now. I have 6 vacancies in my office, and I've been struggling for past 3 months to hire people for those vacancies. And the reason behind is that we are not producing good quality people or human resources that could be absorbed as part of our system. And in that context, a program like GYAN is very, very important because it's trying to fill that gap. But obviously, when you start talking about filling that gap, it's a journey. When you say that you are a student and you want to become a practitioner, it's a journey that you need to go. And I believe that GYAN is the first stepping stone of that journey. You have just started realizing what health policy systems research mean, right? And if you want to be, and I'll share why I'm saying this. When I became a health system guy, I was not an HPSR guy, I was a health system guy. My first job was to distribute that information booklet that you get, right? IC material, in a place which was a public place, and being very specific, the public urinal. I was standing in front of public urinal, identifying males with whom I used to spread information. I used to give that information booklet on HIV. And I'm talking about 2000. My salary was $7,000. At the same time, I was a researcher in the evening when I did my first public health research on masculinity and domestic violence. That was from 6:30 to 8:30. In the morning, post 8:30, I was a coordinator for care home for people living with HIV/AIDS. And I did that job till 12 o'clock at night. And I started my job from 6 to 9 in the morning. And after 9, I used to go and do all this job. So I was working for almost 18 hours a day. I worked for 3 years. But that 18 hours helped me leapfrogging 9 years. What people have attained in 3 years, attained in 9 years, I attained in 3 years. But that allowed me to be here where I am at the age of 50. So the point I'm trying to make is that if you want to dedicate yourself to HPSR, initially it's not going to be a lucrative option. Let's be very honest on that. But if you are there and sustain for 5 years, there is no looking back. So then the question comes that from academics, how do I grow? Now, in my previous session, I explained that HPSR is not only public health system. It's public and private health system. And when I start say public and private health system, the opportunities grows humongously. If you want to start being in the public health system, obviously there are internships offered by national think tanks like National Health System Resource Center, State Health System Resource Center. They have got 2 months internship. They want people with MPH. They have a selection process. Every year they will absorb around 10 to 15 students. You need to keep an eye on that if you want to get into research and policy framing domain. And a lot of interns then get converted into a full-time position. National Health System Resource Center. Niti Aayog. Niti Aayog has got young professional program where again they get interns and they get converted into professionals. Ministry of Health and Family Welfare. Now, over a period of time, most of our health departments or most of our departments are going with this mentality of investing in young professionals. And now, as we saw the interface, if you want to work on access to medicine, then you don't need to be kind of confined to Ministry of Health and Family Welfare. You can go to Ministry of Chemical and Fertilizer as well because they work for market development. How Indian pharmaceutical market will grow. You have got within Ministry of Chemical and Fertilizer, you have got also a medtech department which focus on getting innovative medical devices in our country, making sure that cost effectiveness analysis is done, and then they become part of health system. So when I was doing public health system, the horizon was very small and we never knew about it. But now you guys have n number of opportunities to kind of go and explore yourself. But you can only land there when your foundations are there. If you know the nuances, at least academically, if you are able to converse academically, what health system means, how different facets of health system interact with each other, then there is no stopping. There would be limited resources available at a time, there would be struggle, but if you sustain for a period of time, it will grow up. I am not putting much emphasis on the development sector right now, because the development sector is donor financing, right? USAID, BMGF, they all have internship programs as well. But looking at the current kind of value proposition or current kind of turmoil in kind of global health diplomacy, I would not urge too much on looking on development sectors, but domestic sector, both public and private, are hotbeds and they are looking for good talents. So I'm sure that, again, as I said earlier, that Gyan is first step towards that particular process. So based on that, if you start exploring yourself, and colleagues like us will always be there for you. If you need, reach out to us and we'll help you to making sure that you are guided at the right time, at the right place. Thank you.
Thank you, sir, for this enlightening speech. Now we'll proceed further with the felicitation program. I would like to request Professor Parag Karkar sir and Dr. Abhay sir to start with the felicitation program. Yes. I'll request the participants, as I call, to please kindly come forward and take your certificates. Vivek Kumar, Preeti. Guys, please give a hand of applause. Shubham Babre, Shrishti Sinha, Rama Paranspe, Poresh Giripunje, Rama Paranspe. Siddhi Vasaikar, Sakshi Karvande, Dr. Ajay GV, Bhagyashree Radhakrishnan, Dr. Ashutosh Kothari, Mayuri Bhalekar, Gayatri Patil, Dr. Swanand Tirekar, Sakshi Chavan, Vaishnavi Karle, Dr. Smriti Vispute, Priyanka Gurik,
Okay, the last candidate is Shivani.
Thank you so much, sir. Now I would request Dr. Maulik sir to please felicitate our students for their appreciating work. I would now like to call Sanika Kude. These certificates are for to appreciate them for all the hard work and efforts they have put in organizing the whole 2 weeks course. Pratibha Naraude, Shrutika Tate, Ashwini Kamdi, Rutuja Dikle, Shraddha Borate, Gayatri Margu, Rupesh Penda, and lastly, I like to call Sakshi Hirarkar for all, and thanks for all the efforts. Thank you, sir. Now I would like to call our chief guest, Professor Parag Karkar, sir. We still have pending certificates. I would like to call Abhay sir to carry with it.
Yes, thank you. At the validatory session of this particular program, we would like to take this opportunity to give away our annual awards, okay, for our meritorious students here. So we have instituted Professor Padma Bhushan Professor P.V. Sukhatme Fellowship, okay, and 2 students every year receive this particular fellowship. This fellowship is facilitated by the kind support of Professor Bhushan Patwardhan to 2 students every year in our department. So this year, so yes, what we are going to do is that there are 4 students who got this particular fellowship in the year 23-24. So, I would like to call upon stage Srishti Sinha to receive a certificate for this particular course. Please. Yes. You can take it. Okay. Unfortunately, second student is not here. Okay. But yes, this year's kind of fellows are Shivani Khandolkar, and Gayatri Patil. Thank you, sir. Thank you, everyone.
Thank you, Abhay sir. Now I would like to invite our chief guest, Professor Parag Karkar sir, Pro VC Savitribai Phule Pune University, to address this gathering.
Very good afternoon. This GYAN program on the theme Health Policy and System Research Methodology, an introduction, which was on physical mode for 2 weeks, ending today, and still week 3 is going to be online. So the program has a pause button, physical mode, pause, then we'll continue online mode. The participant from Pune University and other prestigious institute all over India, dignitaries on the dais, Abhay Kudale sir, Maulik Choksi sir, and other dignitaries. The guests who have delivered their sessions for these 2 weeks, and further 1 week you will be getting the knowledge. We have very less understanding about the public health system in India. For 141 million people, the healthcare system, public healthcare system is very, very poor. And private healthcare system has become a 5-star facility. There is a misproportion among the number of people, population, vis-a-vis the kind of bed or doctors available in this country. I'm not a student of medical science. But what I understand is multidisciplinary approach is required. Focus to create, maintain and sustain a system is required. Relevant policy has to be made and then continued all across the country. So equal opportunity, we call in simple words. And methodological approaches are required to be developed by the public health researchers. The outcome which I see is affordability, irrespective of your bank balance or insurance. Minimum level of healthcare should be affordable to every individual. Accessibility within specific distance from your home or native place, it should have basic health facilities available. Equitable facility, it should not happen that only metro city has got very tall healthcare facility, and then when you go little ahead, we have seen in the base of Sinhagad Fort, if you see that we have done a survey with one hospital about the girls and females related to their health issues and then hemoglobin. On one side we have a Sinhagad Fort. If you go in the evening, you'll find all beautiful enlightened Pune ahead. On the left hand side you can see the Panchet water, but the woman in the house has to travel 1.5 kilometers to fetch drinking potable water. And a lot of challenges related to health was faced. Everything is visibly seen, but not accessible. And reliability of the system, it should not be driven by the markets. The World Health Organization is majorly funded by the pharmaceutical lobby. So whatever parameters of basic healthcare presented, blood sugar level, are dominated by the healthcare lobby. It should not happen. The basic healthcare can be driven by the health professional and not the, because if you, I have gone through the story in IIM Ahmedabad. The hospitals were running in losses when it was run by the doctors. And when the professional like business professional and IIM students and management students come into the picture, the hospital has started running in profits. So because our approach is business approach, our approach is the profitability approach, and your approach should be service approach. So I think we have to make that balance. I do not want that hospital should run in losses, but I think reasonability of things should be made available to students. We have good healthcare facilities available for the affordable people and not for non-affordable people. So I think this basic research which enables any state government, central government, all policymakers to take appropriate decision while making their policy. I think your outcome, your research, the GYAN program, all the professionals who are attending this will definitely help it out, because it has to be data driven, because the medical science now works on very extensive data, very reliable data. So I think you will help out in future to make very reliable long-term policies, creating a system for healthcare in this public healthcare, not healthcare only, public healthcare system. Because we have everything in paper, everything in place, but in not workable condition. You can't dare to enter a public health area or health outlet because the kind of surrounding and situations is there. Unsafe environment, I think that has to be made very reliable with the help of all this research. Research is very scientific approach. It cannot be driven by emotion. Most of the time I've seen in many of the field, emotionally attaching to the research get dilution of real research component in that, because we are emotionally driven into the research rather than rationally thinking about the do's and don'ts. Sometimes the researcher fails that this research outcome is not going to get any proper outcome. He want to make it something, because a clear research, which I have seen that after even 2 years, somebody has to leave the research because you are not getting the kind of data which is actually required to do the data. But in practical world, we drag the research the way we want it, and then the reliability of the outcome is under question. So I think by practicing, because health is most important component, so whatever you do in future, I think your conscience has to be clear that value-based, ethic-based research should be there. It should not be dominated by someone who sponsors that research to come with the outcome which is not useful for the people but for the marketeers. So I think I wish you all the best for your research. Keep your conscience clear, because we are talking about the public health, which is a large population. Official 142 crore, but often officially the number is 160 crore people in this country, where some of the tribes we do not know as of today after completion of independence also. So I wish that your research should contribute something to the basic policy changes, basic sensitive changes in this. Then its program is successful. This is a starting 2 weeks and then 1 more week, but I think it will not end with getting the certificate you have got. I think it is a starting point. It start motivating you to do something in depth where you can get a good contribution in changing public policies in the country. India is a large country, diverse country, need very good policies and system in place to have reliable public health care. So I wish you all the best for your research, your patience, because physical sitting patience is going down day by day. So 2 years, Kudale sir and his team and all the stalwarts sitting on the dais kept you engaged, creatively engaged, properly engaged to work in a scientific way, in scientific research of future. Thank you very much.
Thank you, sir, for your inspiring words and to support this initiative. As we have our P.V. Sukhatme scholar of last year here, I would request Parag sir to please felicitate her. Nikita Padtare. Thank you, sir. As we near the conclusion of this session, I would like to invite Dr. Girish Tillu, sir, to propose the vote of thanks.
Thank you. Thank you very much. This is 2 weeks. 2 weeks of hard work, 2 weeks of very interesting learning, and this is coming to an end, but not an end, as Professor Kalkar sir told us that this is just a pause button. But organizing this course was a very, very interesting but tedious exercise, the hard work. And first of all, we are very much thankful to the funding agency, the Ministry of Education, Government of India, and the GAN scheme for this particular opportunity and funding for this particular event. We are again very much grateful to the faculty, the Professor Karina Kilman from the Institute of Tropical Medicine, Antwerp, Belgium, who could spare her time, and she was here. She just left yesterday, and hence the contributing faculty, just like visiting faculty, we also have visiting friends to our department. And Dr. Solomon Salve, he was very much instrumental and helpful in entire course, and we are very much thankful to you, Solomon sir. Thank you very much. Whatever we do here, that has a very graceful support and guidance from our university leadership. We are very much fortunate to have a great leadership who encourage us to do all such routine and crazy thing what we plan. And we are thankful to our Honorable Vice Chancellor, Professor Suresh Gosavi sir, who was here for the inaugural session, and Honorable Professor Professor Parag Kalkar sir, who is Pro Vice Chancellor, who is today with us. Sir, we are very much grateful to you. Our today's faculty was very interesting. These 3 lectures that we had, it was really an icing on the cake. And we are thankful to Dr. Choksi for Maulik Margadarshan and Dr. Gadgil for really a Mukta Chintan that you shared with us. And Dr. Swatiji, that was really a poetry, not just a talk, but you shared the journey with us. We are also thankful to our university administration, finance, management, administration department, and especially Professor Dr. Anupa Kumbhar ma'am, who coordinates all GAN courses from our university. And we are thankful to her. We are also thankful to the guests, to the faculty of our department, Dr. Aarti Nagarkar, Dr. Preeti Chavan Gautam, and our office staff. And most important, our participants. Friends, it is always said that adventures are dangerous. But there is also a saying that try routine, which is lethal. And you are the really an adventurous people who dared to spare 2 weeks of your dedicated busy schedule and try and test this particular course. And this was not a really entertainment. We know this was a hard work. Kalkar sir, these students, the participants, they used to start their work before 9:30, and they used to be here till late evening. And this was really a course that gave really hard work, passionate participants, and a great faculty who really introduced the happenings all over the globe, and we are extremely thankful to participants for your, dedication, passion, and courage to you came here. Hence, that was possible. We are also thankful to our students, our senior and junior students, for their continuous help. Now, the formal vote of thanks really ends, but I should mention something for the person who was really instrumental to conduct this course. My friends, whenever we see beautiful garland, the thread is always not visible. I should tell about a person who was really instrumental, who conceptualized it, who worked hard from every pillar to the post and made it possible. Dr. Abhay Kudale, who is I'm sure the claps, they spoke everything, but he was the person behind this particular course, and we were observing and watching him, his hard work and the pains that he really could take. But sir, now today you are the very satisfied person, I'm sure. So thank you very much. Thank you for your participation, and I request you that we should, all the dignitaries and students, to visit the group work that was displayed on the board. This is the product of the course, and this course will not end, and Professor Choksi sir is here. Sir, the participants, they are going to prepare actually research projects, and these projects will be actually implemented, and such courses, they never end. It is just a new beginning. Thank you very much.
Thank you, sir. Once again, I want to thank all of y'all for being present here. We'll look forward to stay in touch and to meet all the participants during our online session from 17th to 19th of March 2025. Let us continue to work together towards strengthening health systems through research and collaboration. Lastly, I warmly invite all the dignitaries and the participants to join us for lunch, providing a great opportunity to network, interact, and exchange our ideas. Thank you.
Yes, I would request all the participants of this